Yeah, thanks so much, Eric. This is a great pleasure to be part of the symposium this year, invited back. Eric's always done an amazing job putting this together. And the only regret I have this morning is that we're not all together to be in a social environment, but hopefully next year we'll be able to do that. This is an area of great interest for me through my career. It's something that we started early, right after fellowship with Rich Hawkins, and really we're involved with a lot of what we call translational medicine, trying to understand the basic science around rotator cuff disease, how we could influence that with new technologies, show the effectiveness of that with some of the animal work, and then ultimately now look at the clinical effects of this. And it's a really exciting area. We have still a lot to learn. We're working now on a chronic rotator cuff model up at CSU with our team up there. And I'll kind of finish that up with what's the future hold for us. As it relates to my disclosures, let me, for some reason not advancing here, sorry. Okay, here we go. Have no disclosures as it relates to this presentation itself. What do I want to accomplish in the next 10 minutes? There's a lot to cover, but really want you to understand a couple things. What is the natural history of an untreated rotator cuff repair? We've heard a little bit about that in some of the earlier presentations, Dr. Meyer and Dr. Podar, but want to kind of hit that because I think that's really important as we're making decisions. What are the basic science principles that we need to think about when we're repairing rotator cuffs? What are the adverse factors? We've heard a little bit about that from the previous speakers. And then really, what are the future technologies that are promising to enhance rotator cuff healing? Always like to start with a case because I think that kind of frames the discussion. And in this case, we have a 28-year-old right-hand dominant professional football player who presents with complaints of primary shoulder pain at the end of training camp. So these we're always faced with, what are we going to do at this point? We're early in the season. Are we going to treat that patient non-operatively or operatively? And we always want to make these decisions based on the best available literature. So the physician really wants to know a couple of things. What happens if I don't do anything to this player? How's that going to turn out for him? If I wait, am I going to make the condition worse? And I think that's really always in the back of our mind when we're trying to make the decision. Is it reasonable for the player to get back on the field? And what is the timing of that? And what will enhance the best chance for a good outcome? And we want to base this always on the literature, the best available literature that we have. So we heard a little bit about this. Jed Kuhn is one of our great friends down at Vanderbilt and where Eric came from. The Moon Group is fantastic, I think, as it relates to the research they've done. And Jed and I, along with Rich Hawkins and Neil Alatraj, were on these instructional courses over the years talking about the controversies of rotator cuff disease. And I have to say, the first time I heard Jed give this talk, I almost fell over. An orthopedic surgeon talking about non-operative treatment. But the work is good. Dr. Podar has pointed out why this is something to consider. And I think we have to think about this in the scheme of the patients that we're treating, particularly focusing on the word in this title, atraumatic full thickness rotator cuff repairs or tears. And Dr. Kuhn points out appropriately that we don't really know what is the cause of pain in patients. So maybe the cuff itself isn't the problem. Rotator cuff tears can be treated without surgery. That this data shows that. And really maybe the outcome is more about patient expectations. So that's one of the things I think that we really need to consider. Somebody that depends on where they are in a traumatic versus atraumatic, age and expectations are really ultimately going to decide whether a non-operative program is a good way to go. I have to point out this is the work that's been done is a case series level 4 evidence. So not the best evidence that we could have, particularly when we're looking at trying to make great decisions. So back to our player. So we got this player at the end of the season. As time's gone on, he's gone through the season, played. Now he has increased pain and weakness. And unfortunately, if you look at the MRI on the left side, it's a small tear. Now it's become a big tear. And at the time of surgery, we look in now arthroscopically and we see this large retracted tear. So this is a problem from the standpoint of how this patient's going to do with surgery, higher chance for this patient to fail. So the real question is, have we done this player a disservice by allowing him to continue to play? I like to go through this. I think this is really important as far as understanding the natural history of untreated rotator cuff tears. Full thickness tears do not heal spontaneously in humans. So we got to understand that once you have a tear, a full thickness tear, it's always going to be there. Second thing is, full thickness tears do have a risk of increasing in size over time. Many good studies showing that, particularly some of the early ultrasound work done by Ken Yamaguchi and his group. And this is just what we saw on our player, that the tear does have a chance of increasing. We heard about this. Full thickness tears that do increase have decreased strength. So that's going to be more important depending on the type of patient that we're treating. And athletes in particular really want to think about giving them the best chance to compete. We do know that unrepaired tears have a chance to go on for fatty infiltration. So the MRI on the left shows a normal supraspinatus muscle, and the one on the right shows this atrophy that occurs. And at some point that the atrophy becomes so significant that we probably can't actually repair the rotator cuff. This study is actually interesting. I've seen this surgically, and Christian Gerber actually did a nice study looking at the fact that with time, not only do we get this fatty infiltration, but we also get a shortening of the tendon. And as we think about success with repairs, the more tension on the repair, the higher chance for failure. So once that tendon starts to decrease in size, then we have more problems. So where does that leave us? Well, we don't really know the rate by which the tear increases or the percentage of patients that have symptomatic tears. But I can tell you over the years of taking care of patients, we do see the number of patients requiring reverse total arthroplasty is on the rise. And we're really trying to limit that. So what are the factors that are most important in maximizing success with repair? This is some of the work that we did early in this kind of translational medicine. We're really trying to figure out what gives us the best chance. And Dr. Meyer showed that really there are these layers that occur where the tendon attaches to the bone. So any procedure that we're doing, we're really trying to recreate the normal zone of fibrocartilage, cartilage's interface. And that's going to be the success, ultimately restoring the normal tendon. The basic science were particularly early on, we were doing repairs open with transosseous tunnels. We were starting to make a transition to anchors, and we could do that now arthroscopically. So we did show that we could do successful repair by using anchors versus transosseous tunnels. And then we could start to put in stitch patterns that would allow us to get the same success that we did with open repair. So that allowed us for this transition to an all arthroscopic repair technique. It does take time for a tendon to heal, considerably longer than we thought. And some of the work that we've done, Christian Gerber's and others, really show that where we repair the tendon, it often retracts, and this is filled with this gap or a scar tissue, which is not as good as normal tendon. So whatever we do, we need to try to do the best chance that we can to get that tendon to heal the bone. I think this is really important as far as the rehab. We showed that the strength of the repair is very weak in the first 6 weeks, and strength improves. By 12 weeks, the strength of the repair is only 25% of the normal strength of the tendon. So whatever we do with the repair, we need to make it as strong as possible to time 0. And then we really have to be careful with our rehab afterwards. And I think that ultimately will allow for the best success. We've heard why do some tendons why do a lot of tendons not heal? Diseased tissue, poor blood supply, this fatty infiltration, increased force at the repair site, and some of the other factors that we really just can't alter as far as patient's age, chronic disease. So maybe that's where some of the work that we're going to do going forward with biologics will have a big impact. We do know that the size of the tear does affect success. So when we're looking at some of the early work with open repairs, 30 to 50% of the chronic tears failed, particularly the large ones. And Bruce Miller did a nice study with the best repair construct, double row repair, looking at ultrasound studies every 2 weeks, and showed that he still had up to a 40% failure rate. So it's pretty significant. And when they did fail, they usually failed in the first 12 weeks. What you really want to focus on is particularly an acute repair or acute tendon injury. You want to get to that earlier, and you don't want to really wait around a long time, knowing that the chance for success decreases. So what do I want to do? I want to fix small cuff tears in young patients because they have the best chance of healing, and I want to do everything I can to decrease the likelihood that they're going to go on to have significant problems. The future really for us is biologics, and we don't have enough time to really talk about that. I know Jason's going to talk a little bit about it, but this is where all our research is going now from the clinical, from the basic science side, and we're doing a lot of this work now with following patients clinically with mechanical stimulation with pulsed ultrasound, PRP, scaffolds, and so we will report back to you as we have more information. So thanks again for allowing me to participate today, and I'll look forward to the discussion at the end.